Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to start a new series on autoimmune diseases. It's going to take me for a very, very long time to go through all these different diseases that are of an autoimmune nature. Very complicated, fascinating, stimulating discussions. And every single organ in the human body at one time or another have and will be affected with some sort of autoimmune diseases that can lead to a whole lot of major problems. Before I do so, however, I wanted to clarify something. When I ended the show last week having to do with alcoholism, I think I misspoke when I said 1.2 million people in the world abuse alcohol. It's 140 million people in the world abuse alcohol. 2 billion people use alcohol to one degree or another, but 140 million abuse alcohol. I wanted to clarify that. The next thing that really I found shocking, I read an article this week, I think it came out in the Wall Street Journal, whereby, according to the WHO, 20% of the population globally are deficient in B12. And this came out in one of the nutrition journals. That is awful. That is one of 5 individuals in the world, as I speak, has B12 deficiency. And of all the major diseases that can really do damage to the human body, B12 is one of them. So we're talking about 1.54 billion people in the world suffer from B12 deficiency. It is devastating because if you have B12 deficiency and it is not recognized, and then you go on to live without knowing you have it, and you start having symptoms such as numbness in the leg, poor memory, dementia, or whole of seizures, after 5 years, there's nothing you could do to reverse those things. And the problem is, we're dealing in a world right now with, for these many people to have B12 deficiency, which is a crippling disease. And in this part of the world, we were taught when I went to medical school and into training that you look at your blood count and you look at the indices, you see if the red blood cell is too large, the MCV is high, that gives you suspicions that somebody may have B12 deficiency. Because of delay in maturation of the red blood cell, because of the lack of the B12, the red blood cell remain large, that causes the MCV to be high. The normal MCV can go as high as, let's say, from 85 to about 96 thereabout. That's the size of the red blood cell. But what needs to be known in modern 21st century medicine is the fact that if you're waiting for anemia to show up when you are B12 deficient, it will be too late. The only time you could pick up B12 deficiency anemia very early on if the patient has pernicious anemia. But pernicious anemia is very rare. It occurs mostly in young Negro men and women or young people from Scandinavia. Why Scandinavia? Don't ask me. And these people get sick so quickly, they become anemic so quickly because it's an autoimmune phenomenon. Things are being destroyed so fast. And you could quickly make that diagnosis, and you have to make it quickly, because if you don't, your patient is going to get into major problem. That's a different part of B12 deficiency. I have here in this book, African American Women Health, that came out about 6 weeks ago now, okay? That covers women of color across the world. Chapter 66, I usually don't do that, to read things to you. Chapter 66 have 18 different things. 18 different things that can cause B12 deficiency. 18 different things that can cause B12 deficiency. And I'm not going to bother to read them to you. So this is crucial. It's something as simple as that. And B12 can be found in many different types of food. And one can buy B12 without prescription over the counter. Put it under the tongue. It will do the same job as if you take it by injection in certain set of circumstances. And yet, for that many people to have this crippling disease, one of the leading causes of dementia in the elderly is B12 deficiency. And this is not a show about it, but I was so taken aback by this, I thought I ought to mention it. 1.54 billion people, 20% of the 7.7 million people in the world suffer from B12. It's 1 out of 5. This is unbelievable. And B12 is all over the place. However, before I came here, I wanted to look over the counter in my office. There are 5 different little flasks there with B12 in them, of people that I diagnose with B12 deficiency. That has nothing to do with the red blood cell being large, etc. Because that's how I practice. I do these things, and all these individuals wind up having B12 deficiency. They knew nothing about it. So every month they come to get their injection. The reason is because we have 5,000 microgram of B12 in the human body. 5,000. We lose about 0.05 microgram per day, unless of course we're eating to replace it, etc. Through the skin, sloughing from the large bowel, etc. So it will take 10 years to become completely deprived of B12 for the anemia to start to set in. By then, you're already crippled. Therefore, then, and another thing to let you know how serious that is. Look at all the different people in the world who have alpha thalassemia. All the people in the world who have beta thalassemia. All the people in the world who have hemoglobin C. All the people in the world who have hemoglobin E, hemoglobin lapore. All these individuals have a condition called erythrocytosis with microcytosis. They were born with that. So therefore, for the rest of life, they will never have enlarged red blood cell. Never. Because they were born with this condition that causes a red blood cell to be little, much more in terms of million, but little tiny. So that's the way they were born. That's how you could pick up this abnormality at the bedside. And then you do your quantitative immunophorensis to find which one it is. And I was teaching that to the student yesterday. So in the black community, let's give you an example. Let's look at the African American community. 32% of African American in this country, or for that matter across the world, carrying the alpha thalassemia gene. In this country, 30% are missing one alpha globin chain. They're not anemic, so don't look for the anemia. That's not going to tip you off. And 2% slightly anemic because they're missing 2 chains. All these individuals will never have enlarged red blood cell under any set of circumstances. You're not going to see it. Because as you do the blood count, it comes out of the computer, they're always going to have erythrocytosis with microcytosis for life. They were born like that. So if you're waiting for look at that many people. There's about close to 45 million black folks in this country. I'm just using that as an example that you deal with every day. And I'm saying to you, 32% of them, you will never see their red blood cell count becomes enlarged because they have erythrocytosis with microcytosis. They were born that way. When you're looking at the red blood cell and looking at the indices, the total red blood cell count is very high, maybe 1.5 million to 2 million different than the percent of hematocrit, because for every, let's say somebody's hematocrit is 30, you're supposed to have 3 million red blood cells to match it. Not in this setting. It's going to be 5.5 million, 6 million for life. Because of that, the MCV is always going to be in the 60s. Okay? I mean, and this is modern medicine. And this is simple. You don't need to have $1 million machine to figure this out. All you have to do, see that at the bedside or in your office and order a quantitative hemoglobin electrophoresis that takes about a few days to come back. It's going to break it down for you which one that the patient has. If the condition persists, the patient exists, and the hemoglobin electrophoresis comes back normal, you just diagnose alpha thalassemia because by the process of elimination, it's alpha. I, that is not that difficult for anyone to figure out. And that can save people's life. So if you're waiting for somebody to become anemic to diagnose them with B12, that makes no sense. So what you do as part of your routine evaluation to see patients, you have a responsibility to check the B12, to check the ferritin, to check the thyroid, to check the cholesterol, to check the urine, to do all that stuff as part of it. And if you understand, you know the person's ethnicity, you do a hemoglobin electrophoresis on everyone, every individual of color, and everybody who came from, like, say, Greece or Mediterranean. These people have a high incidence of thalassemia. So you do the hemoglobin electrophoresis on them as part of your evaluation. That means that you know the ethnicity, you're not discriminating, you're not profiling them, you're just practicing high quality medicine. You owe that to the patient. Because if you don't do that, I don't care how smart you are. And believe me, there are tons of very smart doctors out there. But you have got to know who you're practicing the medicine for so that you follow the ethnicity of that individual so that you know what diseases they're more likely to have. The same thing, what symptoms these different people, different ethnic group present with different symptoms, even if it's the same disease, it presents in different ways. It sounds like I'm pontificating, but I'm not. When you have an M.A.C.P behind your name, you're representing, in some sense, the profession of medicine throughout the world. So I can sit here and tell you, you have got to change the way it is done. That is why the AMA and the powers to be in this country are now making the change. And for those of you who are going to take exam, as I taught my students yesterday, they're going to show you a case of somebody with thalassemia, or no matter what it is, it could be beta, alpha, whatever. And they're going to show you the erythrocytosis with microcytosis. They're even going to show you the smear that's going to be, and they're going to ask you, what is the diagnosis and how do you proceed? Right away, you know you're dealing with somebody with some form of abnormal hemoglobin because as you look in the example they gave you in the exam that you've taken, you see erythrocytosis with microcyte. Right away, you know that can only occur if the patient has an abnormal hemoglobin. You know that. That's what I told my students yesterday. So therefore, then you go right ahead, you skip all the other crazy questions they ask you. You pick the one that say quantitative hemoglobin electrophoresis. And voila, your diagnosis is established and you move on. Okay? All right. So now then, what I'm doing in this segment, putting aside my venting about, and the reason why that is touch a nerve in me, because they talk about nutrition. You have people that are starving across the world. Many of these folks who have low B12 are people who are starving. And I starved as an orphan in Haiti. I did. I starved. I suffered from hunger like you couldn't probably imagine. Okay? So I'm very sensitive to that issue when I hear people hungry and people starving. That is why years ago I set up my own personal corporation, Alcena Africa Hunger Relief Fund, whereby I send money to different places to try to help the ease for people who suffer from hunger because of my own personal experience with hunger. Okay, so that being said, in this segment, what I really want to talk about is autoimmune diseases. And the list, of course, is long. So I'm going to be here for months talking about autoimmune diseases. Okay. However, to start off, I'm going to do the obvious thing. Let's talk about the blood cells, the red blood cell, the white blood cell, and the platelet. And then we'll move on over the next many weeks to talk about the other different part of the organ in the human body, organs within us that can develop autoimmune diseases and have developed, and the different medications that are also can cause somebody to develop autoimmune problem. So to get started, I copied chapter 14 in a book that I will not name that I'm writing right now because I haven't copyrighted it yet. So I don't want anybody to know the title of it. When I do, that's next year's book. So chapter 14, and I copied that chapter 14 on autoimmune hemolytic anemia on a book that's coming out next year. The title, forget about it. I'll let you know next year. So we talk about the red blood cell because without the red blood cell, we can go nowhere because we need the red blood cell that contains the hemoglobin to which the oxygen is attached to keep us alive, to carry oxygen, to perfuse the body with oxygen. Very, very important. And as I mentioned before, I'll go over this little detail for you. When someone is anemic, the reason why they suffer so much tiredness, headache, insomnia, weakness is because the oxygen dissociation curve is shifted to the left. If you can imagine an invisible curve that's standing right in front of you and it's shifted to the left. When it goes to the left, the red blood cells are holding onto the oxygen. They're holding onto it, absolutely. They're not delivering it anywhere. That makes sense, okay? And that's what severe anemia, it doesn't matter the cause of the anemia. That's why you're suffering so much of tiredness, headache, insomnia, depression, palpitation, you just name it. You have to do something, first of all, to diagnose the anemia, to find the cause of it. And whatever you're going to do is going to help to shift the oxygen dissociation curve to the right. Only when that curve is shifted to the right, that invisible curve, is the red blood cell going to release the oxygen. That's why it's going to carry the oxygen and release it once it is shifted to the right. So you got the middle to work with. You have to do everything you can to shift that curve to the right by whatever treatment you're going to do, to so on and so forth. That's why I talk about blood transfusion and so on and so forth. But autoimmune hemolytic anemia is a disease pretty much of unknown cause, and many things can cause it. Unknown causes and many things can cause it. Okay, it's a form of anemia whereby there's an antigen that's developed in the body, and the body is fighting against it. So you have this fight going on, and then the antibody doesn't belong there. It develops, and then you have an antigen-antibody complex. That complex then attaches itself on the surfaces of the red blood cell and destroying them. That's right. It is the complex of the antigen-antibody together that sit on the surface of the red blood cell. The problem is that where did this antibody come from? Where does it come from? Because the body is not fighting against it. Where did it come from? That's the mystery. And many of these things still remain mystery. We still don't know why. We know that we still don't know where did it come from. Our job is to try to diagnose the problem. So somebody, therefore, with let me give you an example of the different diseases that can be associated with autoimmune hemolytic anemia. It means that the red blood cells is hemolyzing, breaking up, dissolving itself, as it were, in the circulation, releasing its content. Some of them are very toxic into the bloodstream. Okay, let me put these glasses on so I can read some of this stuff for you. I have here chronic lymphocytic leukemia, non-Hodgkin lymphoma, ovarian cancer, systemic lupus erythematosus, multiple myeloma, AIDS, hepatitis, rheumatoid arthritis. And then the biggest list of all is something we call mixed collagen vascular diseases. What are these? Well, these are when you have one rheumatological problem, no matter which one, and there are many, you live long enough, you're likely to have a second, sometime a third. And that's what's called mixed collagen vascular disease. That's several of them mixed together. So they call them mixed collagen vascular diseases, and that's what that is. All you have to do is live long enough. Believe me, if you have one, because what that means when you have one, now you have a body that's capable of reacting against itself. So if it reacts against itself once, what's to prevent it from reacting against itself a second time or a third time? You got the idea? Okay, good. Now let's take on a list of drugs, some of them common medication that can cause somebody to develop autoimmune hemolytic anemia. Quinidine, we still use quinidine. I still have patients, believe it or not, on quinidine. Metal-dopa, hydralazine, Tylenol, all the ibuprofen can cause it. Alpha interferon, cephalotin, insulin, all the sulfite drugs can cause it. Hydrochlorothiazide, rifampin, streptomycin, penicillin, etc. The list is infinite of different drugs that can cause somebody to have an anemia, which is autoimmune in nature. Okay? So, the question then, there are other diseases as well. I didn't mention ulcerative colitis, myasthenia gravis, ITP/Evans syndrome. I'll mention those later when we talk about the white blood cell, etc. So I'm talking about mainly in this segment about red blood cell, autoimmune diseases that affect the red blood cell. So the symptoms will be then weakness, lassitude, headaches, shortness of breath, palpitation, insomnia, depression. All sorts of stuff can happen. And the patient then present with you with this to the doctor with this list of symptoms. Okay? Now you have to understand, not all the autoimmune, there's warm, there's the cold. Okay? So 50% of them are warm antibodies, the others are idiopathic. So you got to be careful. So you take the history from the patient, you carry out a thorough, the history must include where has the patient been? Has the patient traveled overseas recently? The patient work. Where does the patient work? What can he or she may be exposed to? Very important. Okay. What diseases the patient may have had in the past. You take a thorough family history. Because if the patient has family history of cancer, you keep that in the front of your head because you're thinking that he or she may have occult cancer as well that has not shown itself, so on. The work-related thing is very important because exposure to work-associated toxin can be involved. Traveling is very important because the patient may have picked up something through places that she traveled and so on. The habits. I mentioned hepatitis. Does the patient have hepatitis? Does the patient use intravenous drugs? Did the patient get transfused with blood that may have transmit hepatitis to him or her? You don't know. All sorts of things. So now that you get your history, the family history, the work history, the patient habits, and so on, then you're going to carry a thorough and complete examination. I mean thorough, because the hair, somebody may have alopecia. Have an area where they lose their hair, alopecia. Sometimes it's the eyebrow. Out of the brow, the patient's eyebrow is being lost. That may be a key, because some autoimmune diseases can present that way, such as lupus, for instance. A rash can have 1,000 different reasons why people have rash, but sometimes one of the first indicator that somebody may have, let's say lupus, for instance, could be a rash. And then you take it from there. Then when you finish with your thorough and complete examination, but I mean really complete and thorough, neurological, examine the skin thoroughly, do all that you're supposed to do a complete examination, the patient height, the patient weight, and so on and so forth. And now you're going to get started now to start doing some blood work. Or let's say blood tests or lab work completely. You're going to send a complete blood count, complete chemistry profile, urine analysis. Then you want to if you're talking about autoimmune now, you will get yourself a sedate because the sedate is key. You're going to do also a rheumatoid factor because rheumatoid factor can be associated with autoimmune hemolytic anemia. Then you do an ANA, crucial. Every time you're talking about an autoimmune disease of any type, you must do your ANA, you must do your sedate. Those are required. That's going to set you on the path. And then a very crucial test, you do a reticulocyte count. What are reticulocytes? They're baby red blood cells. The more the patient is hemolyzing, the higher the reticulocyte count is going to be. Because the reticulocyte tell you four things. Is the patient anemia normocytic? Is it hypo or is it hyper? Normocytic means that the reticulocyte count is normal. Hypo means the reticulocyte count is low. Hyper means it is high. The patient is hemolyzing. And then the autoimmune disease, autoimmune hemolytic anemia, the patient is hemolyzing. So you expect to have, and the reticulocyte count directs you how to navigate. So you don't have to spend a lot of time in the dark not knowing where to go. Just like you're in the middle of the ocean, you need a compass. If you understand how to use the reticulocyte count, it will be your compass so that when you're in the middle of the ocean of the medical symptom, blah, 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 it will direct you to shore. But you have to understand how to make use of the reticulocyte count to your advantage, to the patient advantage, to the patient's benefit, so that you don't throw away money all over the place or doing all kind of tests that are unnecessary. When the reticulocyte can already tell you what you're dealing with, then you know how to handle it, how to proceed. Listen, I want to stop here until I see you again. This is Dr. Alcena saying so long and bye-bye.